Can you use a microphone, please?
Okay, I'll try. Because I have very loud voice usually. Okay, so thank you very much for inviting me to this nice conference, and thank you, Dr. Baum. I'm going to talk a little bit about hepatic arterial embolization and primarily to use our unique technique. But a little bit introduction. So I would like just to emphasize how important to diagnose and properly treat metastatic disease to the liver from neuroendocrine origin. So if previous speakers have explained already that hepatic metastases in patients with digestive neuroendocrine tumor are frequent, and they could present from 1/4 to 90% of patient population. 5 years survival for the patient with hepatic metastases and without metastases significantly different, up to 40% of patients with no liver spread and up to 99-75% patients with liver metastases. So National Institute of Health found that 10-year survival went from 96% in patients without liver metastases down to 85% of patients who develop metastases during follow-up, and only 26% in patients with liver metastases at the diagnosis. For pancreatic neuroendocrine tumors, as you know, it's a little bit different prognosis compared to carcinoid tumors. So 5 years survival for pancreatic neuroendocrine tumors is 40% with and 100% without liver metastases, close to 100%. So liver metastases, as you know, may secrete different hormones like serotonin, VIP, glucagon, insulin, and it's resulting in clinical symptoms which are difficult to control, and patients suffer most of clinical presentation of secreting tumors. So liver metastases of neuroendocrine origin are frequent, and it frequently diffuse at the time of diagnosis, and curative surgical options are limited. So the principle, in general, principle of managing of patients with liver metastases, it's actually different at three large pathways. It's the first, of course, it's improving quality of life, because, as you know, our survival is relatively long, but the patient is suffer of symptoms. So we need to emphasize our therapy to control of the symptoms. Definitely we can follow patients and use their biomarkers as a response to the therapy. As you know, this is 5-HIA, chromogranin A, and specific hormones like VIP, glucagon, and insulin levels we can follow. And we would like to give a therapy which actually causes significant decrease in this substances. And of course, our treatment is needs to try to shrink the tumor as much as possible. As you know, the carcinoid tumors, for example, it's very actually different to achieve significant shrinkage in the tumor because we have a thick capsule, a fibroid capsule surrounded it. Okay, so what we usually have is previous speakers have spoke that usually surgery is only curative modality for these patients. And it's in comparison to patients with other tumors and liver metastases, actually for neuroendocrine tumors, metastatic deposit debulking actually significantly improves quality of life. Of course, for minimal liver involvement, we can use radiofrequency ablation or cryoablation and laser therapy as well. As you know, chemotherapy, one-agent chemotherapy doesn't work very well, and even with multiple agents, results is not very promising in patients with liver metastasis again. So alpha interferon and cytotoxic agents as well included in this group. Okay, so what we have as the options of embolization of liver metastases. So we have a couple of options. We have transcatheter arterial embolization with gel foam or glass or resin beads, alone or with radiotracer in it. We have chemoembolization with chemotherapeutic agents. We also have cold, which is not radiolabeled, or radiolabeled with iodine 131 lapidol. And all these combined techniques could be used to compromise tumoral blood supply, cytotoxic agent delivery, and application of beta radiation to the tumor. I haven't told that iodine 131 has a high energy beta emission. So delivering directly to the tumor is provide a high radiation exposure to the tumor directly. Okay, so here is the explanation why it's actually arterial hepatic embolization does work. Because as you know that normal liver parenchyma received only 25% of the blood supply from hepatic artery and 75% from the portal vein. In comparison to this, a tumor in the liver actually almost completely receives blood supply from hepatic artery. So if we block this hepatic artery specific branch going directly to the tumor and deliver chemotherapeutic agent inside of the tumor and give radiation as well there, so we actually achieve a good response with minimal toxicity to the rest of the liver. So what is lapidol is? So lapidol is naturally iodinated fatty acid ethyl ester of poppy seed oil. So what's going on after embolization? So we need, first of all, we need to find the right artery which supply blood supply to the tumor. So after hepatic intraarterial injection, lapidol actually follows arterial flow toward the tumor, and it's trapped by tumoral microvessels. So up to 10 to 25%, it's actually shunting to the lungs, and it is one of the limitations of this therapy. I will mention a little bit later. So we always see some kind of shunting. Even we localize the vessel properly, and it's radiotracer going there, up to fourth of those could go to lungs and cause some problems. So we need to be very cautious about this. Okay, so radioactive lapidol. So lapidol labeled with iodine 131. As I told you, this is beta pure. It's not pure, but beta emitters. It's derived solely from radiation. The therapeutic effect of this drug is opposite to ischemia associated with chemoembolization. And 90% of radiological effects results from short-range beta radiation, which favors destruction of tumoral cells surrounding microvessels containing high iodine lapidol concentration. So now I will present results from our multidisciplinary group involving Dr. Reed. You know him. He's a nuclear medicine physician. Dr. Kocher, he's an oncologist. Dr. John Elliott, he's our invasive radiologist who actually defined the vessels for us and have this procedure. And our perfect staff, Rosemary Davison and Wendy Gillis, they're our nurse and nurse practitioners who actually help to treat and follow these patients. So it's actually without multidisciplinary team approach, we couldn't be able to provide this therapy to our patients. So in our specific protocol, we use 3 different therapeutic approaches which we synergistically apply. This is beta radiation from radioactive lapidol. It's local cytotoxic effect of high doses of doxorubicin and cisplatin, and profound tumor ischemia and tumor hypoxia secondary to arterial embolization by J form and the end, which known to potentiate the effect of chemotherapy. So the purpose of our small study, it was to retrospectively assess the safety and survival rates of patients with neuroendocrine tumor hepatic metastases who were treated with combination of radiolabeled lapidol, doxorubicin and cisplatin, and transarterial hepatic embolization. So we included in our study 39 consecutive patients with unresectable hepatic metastases, selective catheterization of right or left hepatic artery, only one vessel per procedure was done for the safety reason. Mixture of not radiolabeled lapidol, and high doses of doxorubicin and cisplatin, each of 50 milligram, were slowly injected following by vessel embolization by gel foam. So in total, 103 embolizations, up to 6 embolizations per patient, with median 2.7 embolizations per patient, depending on response and tolerance. We applied, and time between embolization was 5.6 months and median 4.5 months in between procedures. So follow-up from the time the diagnosis was to up to 14 years and median 2.5 years, and the follow-up time from the first embolization was up to 4 years and median 2.5 years. So we evaluated response to each therapy 6 to 12 weeks post-embolization. So how we evaluated response? We actually evaluated 3 different responses. First of all, as I told you, because the clinical symptoms, it was very important to evaluate the clinical benefit. So we evaluated it by decreasing or evaluation clinical symptoms, somatostatin consumption, and performance status, and we used ECOG system. So we also evaluated response to the therapy using their available biomarkers. Patients who produce 5-HAIA, we use 5-HAIA. Non-producers, we use chromogranin A and other, depending on the tumor type. And of course, radiological evaluation was done using a tumor shrinkage calculation. So it's a little bit busy slide, but you can see our patients who were included in our patient group. As I mentioned, we have total 39 patients. Majority of them were carcinoid tumor, 30 patients. Now 8 patients were with neuroendocrine pancreatic tumors, and 1 patient with well-differentiated neuroendocrine tumor non-specified. So you can see there were no significant, you can see that's about 47% of the patients of carcinoid group were male and about 53 female, and we have more male in our pancreatic group, 75% versus 25% of female. There were no significant difference in the patient age. You can see their mean age was around 50, 55. Liver metastasis, bulkiness of the liver metastasis. So we found that most of our patients had liver metastasis at the time of the diagnosis. So some patients had extrahepatic spread as well, and about around from 55 to 60% of patients had disease outside of the liver. So, extent of liver metastasis. You can see that more or less the group are equal. Around 67-66% of patients had actually quite advanced liver disease. Less involvement is 50%, and about a third of total patient group had more advanced disease in the liver. And as most of the carcinoid tumors in our group, about 80% of patients were hormone secretors, only 20% were not secretors, and we have a functional, non-functional neuroendocrine tumor 50-50%. Okay, so evaluating adverse reactions of our procedure, we have found that 84 embolizations, around 82.6%, were actually tolerated quite well with only very mild side effects. About 5% of procedures were technically complicated as expected because anatomy of the vessels were some problematic. We had 2 patients with complicated anatomy. 2 patients actually had leaks of mixture during the procedure, and 1 patient has significant arterial spasm, which actually caused significant difficulty during injection. So about 13.6% of procedures were associated with carcinoid crisis or severe pain. So what I wanted to emphasize, and you can ask Dr. Reed later about this, In the later years, the protocol to prevent carcinoid crisis have been developed, and we have all medications aside now, and we try to pre-medicate patients prior to this procedure, avoiding significant carcinoid adverse reactions. So post-embolization, what happens? So as expected, all 103 embolizations were associated with liver enzyme elevation, and the highest level usually right away after embolization with gradual decrease over time. 4 patients, 10% of patients developed liver abscesses during the follow-up, and this is one of significant severe complications of embolization. 1 patient died of acute infection and tumor necrosis and acute intrahepatic bleeding a week after second embolization. So lung shunting, as you remember when I start my talk, I told that all patients during this procedure shown some shunting. So we have calculated shunt during the anterior-posterior geometric mean calculation from planar images, and because this high radiotracer activity within the liver parenchyma, I would tell that about 10% we overestimated the shunts. So now we use a SPECT-CT procedure to evaluate the shunting, so we get more precise numbers. Even though, based on our old technique, you can see there's only 13 procedures were associated with significant shunting, and acceptable shunt, it's up to 25%. So 13 procedures were associated with high shunting, but none of the patients actually have developed any significant lung problems. So, in response evaluation, so clinical benefits and decrease in biomarkers were achieved in 92.3% of patients, which is quite high number. Radiological stable disease was found in 84.6% of patients. It's 33 out of 39 patients with partial response in 3 and complete response in 1 patient. So you can see the duration of responses were also quite prolonged, and there were no significant difference actually in response between carcinoid patients and pancreatic neuroendocrine tumor patients. There were no significant difference in clinical benefit, but you can see their response actually in carcinoid tumors were longer, up to 3 years median time. So biomarkers lasted a little bit shorter time, 25 months in median and 19 months in pancreatic tumors, and the radiological response was shorter one, is about 17 months in carcinoid group and 9 months in pancreatic groups. So outcomes related to tumor type. This is after our final analysis, we have found the stable disease was found in about 50% of patients with carcinoid group and only 12.5% in the patient from the carcinoid, from the pancreatic group. Disease progression was seen in 30% in the carcinoid group, in more than 50% in pancreatic group, and total 8 patients died, 6 patients from the carcinoid group and 2 patients from pancreatic group. So you can see the graph is actually emphasize that the number of embolizations, as I told you, some patients had up to 6 procedures, so the number of embolization actually significantly prolonged the time to disease progression. So Kaplan-Meier survivor curve demonstrates here, and we calculated it from the first embolization. It's actually in a 4-year survivor from the time of the first embolization was 60.5%. So by 4 years of our follow-up, we has not get a median survival. So there's some points for discussion from my talk. First of all, the significant adverse effect of embolization were relatively rare in only 13% of the patients. And in comparison to other literature, so most reports related to chemoembolization and embolization for neuroendocrine tumor liver metastases showed median survival up to 3 years. So our 60.5% 4-year survival is significantly better results. And again, the one paper being published a few years ago from John Bascom group in England, they showed only 1 year survival because they followed only 1 year their patients. And they actually used hepatic intraarterial embolization by hepatic intraarterial therapy with specific tracer for neuroendocrine tumor. And this is lanreotide. This is octreotide analog labeled with yttrium-90. So the patient group was quite similar comparison to ours. So they analyzed 23 patients, 4 with pancreatic tumor, 1 with neuroendocrine tumor, non-specified, and 18 carcinoids. And they actually reported 63% of total survival, 1 year survival, and our survival, 91% of the first year, is much better again. So in conclusion, I would like to tell that combined therapy using lapiodol, iodine 131, doxorubicin, and cisplatin technique is actually very safe modality, even in high-risk patients. Long-term palliation from this therapy could be achieved with repeated sessions, and patients with carcinoid tumors had some better response to the therapy compared to the pancreatic neuroendocrine tumor. Thank you for your attention.
Thank you very much for the nice presentation and the really encouraging results. Are there questions? Please, Dr.
Can I ask you about, you had 13% carcinoid crisis, and what is your new program for preventing this complication? Are you infusing somatostatin analogs? Are you doing it before or after the procedure?
Okay. Thank you very much for this nice question, because unfortunately I'm nuclear medicine physician. I'm not having been involved in this new protocol, but if Dr. Kocher in the audience, or Dr. Reed, he's organizer. He's supposed to answer a question. I'm sorry, I find him in the middle of the break, and he will answer your question. Okay, because when I actually analyzed these results, I've been involved during my research fellowship program, and then I moved to my specialty in London. It's actually thyroid cancer. So I'm involved with neuroendocrine tumor program, but it's more involved with thyroid cancer program. So probably Dr. Kocher will give you a talk about this. So we actually have developed a very nice protocol, and we have it written down, and you can get it. Even I can get this protocol for you and send it to you.
Okay, these are some technical details. I think they're very important, but we can discuss
it's very important,
during
and I will try
break.
to find the right answers for you.
Okay. There's another question from Dr. Nissen.
First of all, radiologists help us to estimate that. And second of all, if the patient with significant liver involvement, as you may see, we embolized only half of liver one time. So actually, we quite successful, and none of the patient actually died of decrease in liver function, dramatic decrease in liver function.
One more question, please.
I think it's very interesting to potentiate the radiation with chemotherapeutic agents such as cisplatin, which is known to potentiate radiation. However, it's also known that hypoxia is known to decrease the effect of radiation. Your high frequency of stable disease, which is probably enough to control a slow-growing tumor, is interesting, but your partial response rate is very low. Do you think that could be higher if you had omitted the particle embolization and only used the cisplatin and the radiation?
I think so. It's a very good question. Actually, I have expected this question because I was interested if somebody will catch this. Exactly, we know that actually the good oxygen supply is potentiate response to radiation. But we actually paid more attention trying to potentiate the chemotherapeutic therapy as well. So we probably need to remodel it and develop the two different studies and just see whether or not there is any better response when we actually reduce hypoxia and increased oxygen consumption during the therapy.
I have one question which is very important concerning your survival data or progression data. These patients had liver-only metastasis? Or?
No, I mentioned that some patients actually have extra liver metastases, and before embolization, some after embolization, they have actually a systemic therapy as well.
Do you have the data how many developed systemic metastases after chemoembolization?
We had some data that about 30% of the endocrine tumor patient total in our population actually developed progression, and progression was outside
Extra
of the liver.
Okay. Other questions? If not, I think we thank you very much again.
Thank you.
And we are all very hungry now.